Welcome. Today, we are conducting a rigorous examination of renal thrombotic microangiopathy, and we're going to focus specifically on the pathophysiology and clinical management of hemolytic uremic syndrome.
Okay, here's our game plan. We're going to proceed through 5 sections, starting with the broad category of thrombotic microangiopathy, or TMA. Then we'll progressively narrow our focus down to the diagnosis and, of course, the treatment of its key subtypes. So first, we absolutely have to define our core subject. What exactly is thrombotic microangiopathy, or TMA? Fundamentally, TMA is a disease process of the small vessels of the kidney, the capillaries and arterioles. What happens is you get thrombosis or clotting right in that microvasculature. Clinically, this can actually present in a way that looks very similar to a hypertensive crisis. Now, while HUS is going to be our prototype for this discussion, it is absolutely critical to recognize that TMA is a syndrome with multiple, very distinct causes. This includes several rheumatologic conditions of high clinical relevance, like catastrophic APS and scleroderma renal crisis. Now, what's really interesting about this is the incredible specificity of this antibody association in scleroderma. It helps distinguish its TMA from other rheumatological conditions that might more commonly affect other parts of the kidney, like the glomerulus or even the large vessels. Okay, so let's move on and see how this all builds. We're now going to focus on hemolytic uremic syndrome, or HUS, as the archetypal disease to really understand TMA. The classical presentation of HUS is defined by this essential clinical triad: microangiopathic hemolytic anemia, thrombocytopenia, which is a low platelet count, and acute renal failure. And this brilliantly illustrates the causal sequence of events. It all starts with an injury to the endothelium, the lining of those small blood vessels. This triggers a cascade that results in both the consumption of platelets, leading to thrombocytopenia, and the mechanical destruction of red blood cells as they try to pass through these clogged vessels. So the crucial clinical point here is to be able to differentiate HUS from its close mimic, TTP, or thrombotic thrombocytopenic purpura. You do this primarily based on the dominant organ system that's involved. For HUS, it's the kidney. For TTP, it's the brain. We now arrive at what is arguably the most critical classification within HUS, the distinction between the typical and the atypical forms. This is a massive fork in the road. And this comparison really highlights the profound differences in both etiology and outcome. And these differences are what will ultimately dictate your entire management strategy. Typical HUS is mostly in kids, follows diarrhea, and has a good prognosis. Atypical HUS can happen at any age, is complement-mediated, and carries a much poorer prognosis. You see, the serologic signature of atypical HUS is a direct consequence of the dysregulation of the alternate complement pathway. You get this uncontrolled activation, which characteristically shows up as a low C3 level, but a normal C4. This is in sharp contrast to classical pathway activation, like what you might see in a disease like lupus, which depletes both C3 and C4. And the reason for that uncontrolled activation? Well, the most common cause is a loss-of-function mutation in this specific gene, complement factor H. This protein is a key inhibitor. It's one of the brakes on the alternate pathway. When you lose it, you get unchecked complement activation and the subsequent endothelial damage. All right, let's dive into some of the specific clinical details. We'll start with the classic presentation of typical HUS. This timeline is highly characteristic. HUS typically develops as a post-infectious complication right after that initial diarrheal phase. So you have the exposure, the GI illness, and then for about 5 to 10% of cases, just as the GI part seems to be resolving, HUS kicks in. And the cause? Well, the vast majority of typical HUS cases are caused by toxins, usually produced by E. coli 01577 and Shigella species. So let's analyze a really common diagnostic challenge, an acute kidney injury in a child following a diarrheal illness. Labs show a high BUN in creatinine. Is this HUS? Well, the decisive clue here is the BUN to creatinine ratio. A disproportionate elevation in BUN, a ratio approaching 20, points away from HUS and towards a diagnosis of pre-renal failure, which is most likely due to simple volume depletion from the diarrhea. Now, moving to atypical HUS. It's absolutely essential to recognize that sporadic cases can be triggered by a number of therapeutic agents. We see this particularly with chemotherapeutics and with calcineurin inhibitors like cyclosporin. This table really summarizes the high-yield genetic associations in familial atypical HUS. And I want you to notice that, paradoxically, the worst prognosis is associated with a gain-of-function mutation in an activating factor, factor B. So a stuck gas pedal is even worse than faulty brakes.
Finally, let's address the urgent management required for patients who are diagnosed with atypical HUS. This is time critical.
The cornerstone of therapy is immediate intervention to halt the complement-mediated damage. This means initiating plasma exchange, administering drugs like eculizumab, and then managing the long-term fallout. And this really underscores the absolute urgency of starting plasma exchange, or PLEX. It serves as a vital bridging therapy by removing the mutated complement factors from the patient's blood and supplying functional ones from donor plasma. Any delay is a missed opportunity.
So, the crucial point is this: diagnosis and acute treatment are only the beginning. The chronic genetic nature of this disease forces us to consider how to manage its lifelong threat, especially in the very challenging context of renal transplantation. How do you protect that new organ?